It's a pleasure on behalf of PSI to introduce this next section. The focus is sex, gender, equity, EDI, anything that you'd like it to be, and we are so fortunate to have three incredible speakers today to kick us off with the conversation. The first is Dr. Kelly McShane, I'd like to introduce. She has a PhD in clinical psychology from Concordia in 2007 and completed her postdoc training at the Center for Research in Inner City Health right here in Toronto at St. Mike's. She is an adjunct professor in the Department of Psychiatry in the School of Medicine and Dentistry at Western University and associate prof at Toronto's new Metropolitan University, the Ted Rogers School of Management, in the School of Health Services Management and the Department of Psychology. She's worked for various community health organizations and hospitals and does research herself in the evaluation of evidence-based implementation and client outcomes using community-engaged approach to projects, relying heavily on qualitative methods, which we love to see more of at PSI in your grants, or mixed methods. She also uses quantitative measures to assess program and service impact and has been heavily engaged in a lot of social service evaluation. Dr. McShane is a leader in the field of theory-based evaluation for health interventions and has undertaken several realist reviews of health services programs in the area of mental health and addictions. The line of research focuses on organizational development, occupational health and wellness, and change. With community organizations, Dr. McShane develops and tests theories of program change and implementation with a particular focus on health and well-being programs. And she now is evaluating implementation of Supporting Frontline Healthcare Workers program being led by the Canadian Mental Health Association Ontario branch. We welcome her work and acknowledge that it includes issues of harassment and incivility in the workplace. So please join me in welcoming Kelly McShane.
I come to you today, quite honestly, as a replacement speaker. Let's just get the awkwardness out of the room. Okay, so I just want you to lower your expectations for me and know that I'm here to hopefully stimulate some thought, maybe share some laughter with you, and if anything, get you thinking a little bit differently about what EDI looks like in healthcare, which you probably know about, which is why you're here. But maybe talking about what some of the consequences and costs are for not doing it. And I hope to leave you with two exciting examples. One is retro from early 2000s. Those of you who are of a particular age, it will have meaning to you. And one is much more current. So on that note, I will hand over my magic green button. Pardon me, and start with my disclosures, which are that I am a wealthy academic who has tons of money coming from CIHR and SHRC to conduct research. Wealthy is my sarcasm. I also formerly worked at Southlake. I felt the need to say that more for validation, not so much about that I would be discriminated against or something like that. And I do a lot of work in the communities. I'm always happy to talk about what these weird acronyms are. I thought I'd put their logos, but then I ran out of time. And I'm proud to inform you I have not received any funding for today's presentation. I'd just like to put the awkwardness done. Okay, beautiful picture. I teach about teaching, and so I take these learning objectives rather seriously, even if they're developed 1 week before the presentation, as is in my case. And I'm really, truly hoping that we can talk about what some of the unintended consequences are of just kind of being like, EDI, EDIA, all of those acronyms, and sort of just, it being a little bit too forefront, too in our face, not enough, too bright, shiny, scary, uncomfortable. We want to talk about some of those consequences are. And then also come to have two good examples for you that maybe work outside of our system. There are plenty that you can find inside, but I always like to show you the ones that are maybe outside of your traditional systems to spur people on to think a little bit differently. Okay, you are here because you might be on the blissful ignorance side, but I hope in time, in my allotted 12 and a half minutes left, to move us over a little bit to the leader for change. Fingers crossed, I also can bribe you, so stay tuned. I make good cookies and really mediocre artwork. So resistance. You may be thinking of the last time you did wind sprint resistance training, because I did that last night. Sarcasm again. But resistance really is there. I teach on it when I talk about change management. And I wanted to just start by, let's have a conversation about what resistance can look like. Because most of you may be referring and thinking to the left-hand side of this table with small-ish text, I hope you can read it, which is really this active resistance of like, there's no way I'm gonna ask about race data, and oh my gosh, and it's very, very, like, you think that and you're like, Kelly, people don't do that. Like, that they would be called out for being racist amongst many other isms, okay? And so I really want to, number one, tell you what resistance can look like in maybe these very overt forms, but I also want to draw your attention over to the right-hand side, which are some of the ways in which passive resistance can kind of show itself. And it's really some of that resistance that we've heard vestiges of, particularly from my wonderful colleagues before me who spoke about AI, that it's there. It may not be overt and in your face, but it certainly is covert or maybe behind the scenes, okay? Some of you are thinking, that's nuts, Kelly. I'm not sure how this plays itself out for EDIA research. So I want to give you a couple of really concrete examples. I've got evidence for you, so hopefully you'll support me in them. So the first thing is we just block this entire conversation about EDIA, for instance, for gender, by just excluding women, those who identify as women, from all research. We just say, no, you can't be involved in clinical trials. Really simple, done, no problem, okay? So that 1970, that was the movement, just no, okay? Then we have some improvement, but hold your breath, you know that I'm very sarcastic, so we move on to agreement, right? So we agree, but we don't actually follow through. So, you know, the federal government puts out a statement saying, yes, we definitely should work to include women in clinical trials, or those who identify as women in clinical trials. However, did you know it's not mandatory? It is still not mandatory. It is only recommended. So just sit with that for a moment, because I know you were thinking I was going on some history lesson from the 1800s, but I'm not. We're in 2024, so it is still not legally mandatory for any clinical pharmaceutical trials to include women. Because we're just hoping people will do the right thing, right? That's essentially what we're saying. We're not going to make it mandatory. We're just hoping we'll follow through and there'll be no accountability if they don't. The third point that I offer for you is that we run into this situation of using selective facts on whether or not to include women in any of the health research, right? So we go from, oh, they're really not different from men, so we don't really need to include them, or, oh, they're so different that they're gonna make our data super messy. And so both of those lead to this conclusion of, let's not include them, right? So even if legally they don't need to, there are still these vestiges of resistance that exist in REB boards and sort of how they're handling things, okay? So now you want to know what's the cost, right? I think many of you know what some of those costs are. I'll tell you probably two you know and a third one that I discovered last year. So the first and foremost is we just don't have gender-specific treatment pharmaceutical drug recommendation data. We are lacking that data, that knowledge, okay? The next is, without that knowledge, it creates situations where one might be reluctant to prescribe medication because we don't exactly know, right? And so one of the best examples are coming off of everything we know about the treatment for nausea and DES and long thalidomide people, you know what I mean, that because of those consequences to women and their unborn children, that it led to, oh my gosh, I don't know if I want to prescribe if I don't know what's going on, right? So sort of this, with respect, sort of an overcorrective mechanism. So let's not do anything, right? Sort of it's better to do no harm, so we just will delay, okay? The third one, I know if you're wondering if that was like a Canva generated image or if I intentionally selected it, so I did intentionally select it. And this I discovered when teaching occupational health and safety, is that any of our data about exposure to any hazardous materials, it is all about the exposure to men. Almost all of it. And so we find ourselves in this situation where we actually don't have data on what the consequences are on the exposure to hazardous materials, waste, etc. for women. Okay, so that takes you down the path of carpal tunnel syndrome. You can kind of look at that. That's not an exposure to hazardous material, but it is an example of an occupational risk hazard for which women were denied any care because it was not possible for them to be hurt by that, okay? So just some really, really concrete examples for you, okay? I'm hoping no one can now claim blissful ignorance now, right? Because you're not ignorant anymore, right? I don't know if you're blissful. You might be depressed, but I can help you with that if that's the case. But I hope we've moved the dial a little bit for you. And I'm pleased to inform you that as of last night, because I practice just-in-time preparation, my Google search for equity, diversity, inclusion, accessibility medical research garnered 6.89 million results in 0.64 seconds. My AI people, that's what I have to say to you. That was pretty quick, okay? Here's the deal. It's on Google Scholar. We can talk about if that's evidence-based. I'm happy to have that conversation at lunch with you. But I want to say that we have a lot out there, right? We have a lot out there. We have a lot published. And I'm here to sort of nudge you, again, to innovate and think a little bit outside the box. So I hope that the two examples I'll present to you are ones that you may not have heard of. And if they are ones you've heard of, then you can celebrate with me about these great examples. Let's start with Elizabeth. I think her first name is Elizabeth Banks, right? Okay, how many people have seen her? Okay, all right. So I started to read a little bit about what this was. I'm not going to show you the video, but you can find it. I will act it out for you, though, because I'm really good at improv, I've been told. So she's a woman, middle-aged woman, visibly healthy, so no visible disabilities, no trouble breathing, no, tons of medication in her cabinet in the kitchen. She's preparing breakfast for 2 children. Her husband is also getting ready, and she's going through the morning routine, which you may do in your house, and getting ready and just feeling like, it's getting hot. And so she goes through all of these very typical symptoms that you may have, and it never once crosses her mind that maybe, in fact, they are the symptoms of a stroke. And the reason why is because those symptoms that are presented in the video are ones that are very specific to women, but she has not heard or been instructed on the ones that are specific to women, because heart disease is what? A middle-aged, older man's disease. And so this really prompted this move by the American Heart Association to go for the Go Red campaign for women. And they present this great video, and it had such great uptake in it. And so there were a couple of commentaries about having seen that video on YouTube was enough to really offer that education for people to care for themselves better, Okay? All right. Joe Burville. Anyone? Yeah, okay, all right. 3, okay, this is good. I'm getting like only 15% of you have seen my solutions. I'm feeling a little bit more encouraged. Okay, I started following him on LinkedIn, just like I did for Alex, because now I'm currently stalking him. He knows that. I may do the same for you too. You know, I have a number of people in my LinkedIn network who are physicians of color and also academic researchers of color. And someone pointed him out to me, and I thought, who's this dude? And he's a guy in medical school, and he took on presenting a lot of some research that may have been floating around, but had not been taken up and had not been put into the domain in which we can actually bring about that change. Okay, so if you don't know about it, it doesn't matter if it was done, right? Like, so if you're cleaned your room and your parents don't know, you're not gonna get the reward. I know, sort of tangential joke, but I wanted to put this up here for you, and he is publishing, very open-minded definition of publishing, on websites and on social media platforms that PSI is not currently on, which is TikTok and Instagram. Maybe you'll join soon. I'm looking over maybe at Sam. And in his work, he's reaching 1 million people. Do you reach 1 million people? We don't reach 1 million people even if we tried. Okay? Directly reaching 1 million people and has 300 million sort of reposts sort of within his network. So when you think back to any of your early research, many years ago I did research on influence, or opinion leaders as we called them before the social media influencers came to be, but opinion leaders as we were called in the academic, he is your opinion leader. And the good news is that it's not an opinion that he's sharing, it's evidence-based research.
Almost 4 years ago, in December 2020, I made this video about a racial disparity with a device called a pulse oximeter. Pulse oximeters look like this. They're devices that go on your finger and they measure what's called your blood oxygen saturation level. Studies like this one have shown that pulse oximeters are 3 times as likely to show inaccurate, overestimated oxygen saturation levels in patients with darker skin tones. What's crazy is for decades, scientists have published studies in journals like this one about how pulse oximeters don't work equally in darker skin tones. In fact, this article, which says that skin pigmentation and other absorbers impact measurement of pulse oximeters, is from 1976. Yet even now, years after I made my video, the problem still hasn't been fixed and conversations are still ongoing. So here's some updates about what's happened since. First, in 2021, the FDA finally issued a warning about the limitations of pulse oximeters, how they may not read equally in darker skin tones. In 2022, an FDA panel met to review the clinical data about the accuracy of pulse oximeters. Studies from that year found that the overestimation of oxygen levels led to Black patients receiving delayed care when it came to COVID-19. And just last month, in February 2024, an FDA panel met again to evaluate the accuracy and performance of pulse oximeters in patients with darker skin. I'm honestly not surprised how long it's taking to fix this problem. The reason this disparity exists is because it's based on data and research that has historically excluded people of color. So much of medicine is built off of white, able-bodied, male perspectives. And that's why it's so important to understand the biases that exist in technology, how that gets passed down to patients, and how that gets perpetuated in a system.
So when you decide to take EDIA on and champion that in the medical research, and it's hard, and I am certainly not the only one who can speak to that. I just want to remind you that we're doing that because not doing it comes at a cost. That's really what we're talking about. And as we often tell our kids, the greatest things worth doing are the hard ones. And if there's not any discomfort, then probably we're not making that change in the right way. Okay, so thanks very much. I'm going to hand it over to my colleague. I'm going to leave the magic button there.
Here in Canada, and someone who does an enormous amount of national and international work I've looked up to, even though I have never had the opportunity to work with her before, but Paula Rochon is here. She does an enormous amount of work in Toronto and around the country in around the world. Through her research, she explores how medical therapies impact the health of older adults with multiple conditions, particularly women who make the majority of the demographic. She's the chair of the Retired Teachers of Ontario in Geriatric Medicine to try to reimagine the aging process at a population level. Her research also explores societal health challenges facing older adults, how women and men experience health and healthcare differently. She is Vice President of Research and Senior Scientist at Women's College Hospital, Senior Scientist at the Institute for Clinical Evaluative Sciences, Adjunct Scientist and Staff Geriatrician at Baycrest, and Professor of Geriatric Medicine and Professor of Medicine in Clin-Epi at the University of Toronto. Informed by her experience as a geriatrician and practitioner, and I know an amazing mentor, Dr. Rochon is leading work that is going to inform today what she tells us about age, chronic conditions, multiple medications, always, I know, with the EDIA lens. And we're grateful that you're here, Dr. Rochon. Thank you.
Well, thank you very much for the introduction. And so this is my objectives for today. So we're going to be focusing on the idea of sex and gender. So I want to talk about sex and gender and talk about age disaggregated data as well as one of the mechanisms that we're going to use. And think about how do we integrate sex, gender, and age considerations into our research so that we can improve health and well-being for older adults, but especially for older women, which is a group that I focus on a lot. And think about tools to help report sex and age disaggregated data. So thinking about some of the practical things related to putting in our grant applications. And I don't have any financial support related to this session. So when we think about sex, gender, and age differences, I think it's important to think about why they really matter to our research and care. And it's important to think that research has historically underrepresented women and older adults. And this is something that's very important to me as a geriatrician, something that I often think about. And data are rarely reported separately for sex and age. And it limits really the opportunity to think about how we might tailor our care to older adults and into women and men. Now, the picture I have here I really like because it sort of speaks about what happens in the real world, shall we say. Because when it comes to most industries, when you think about fashion or you think about footwear that's displayed in the image here, or all sorts of personal care products that are out there, everything is customized. So it begs the question of why do we have to settle for this idea of a one-size-fits-all approach when we're doing our research? It just really doesn't make sense. And the results of having that sort of one-size-fits-all approach is sort of what we just heard about. You end up with older adults, potentially, and women getting therapies perhaps that aren't the right thing for them and having complications that they don't need to have. So we're going to be talking about sex and gender. So I think it's really important to define the terms because I think they're not always clear to people. So when we think about sex, we're thinking about biological pieces, so the biological attributes. That's what we're thinking about with sex. Now, gender is something different in that we're thinking about sociocultural factors. It's something that's socially constructed, and it talks about roles, behaviors, expressions, and different kinds of identities. This is something that I think is really important for us to think about. And because it's so important for research, we developed a series of metrics to help people assess the quality of how well they included sex and gender in their research proposals. We developed it actually for the Ministry of Health here in Ontario so that their reviewers could see how well sex and gender was included in submissions to them for funding. But I think it's also very helpful to people who are preparing the proposal, so perhaps a number of you in the audience as well might find it interesting. Now, the importance of incorporating sex, gender, and age into health research goes back quite a number of years. And it speaks to perhaps the fact that we really need policies to be in place to make sure that these issues don't arise. As you had also mentioned just a few minutes ago, it wasn't until the 1990s in the United States that it was required that women should be included in research that was funded by the National Institutes of Health, which is their national funding agency. But it wasn't, the part that I find most shocking for us is it wasn't until just a couple of years ago, 2019, that there was a requirement that older adults needed to be included in research funded by the NIH. And this is important because you can imagine that a lot of this work is leading to therapies that are going to be used by older adults and especially women, and we may not have the very best evidence to help support their use. Now, you also mentioned, or we saw the video of the heart attack scenario for a woman, and I think that's something important to think about, because when we just think of everything being the same and sort of the one-size-fits-all approach, you miss important differences. And what I've got here is from some work that we've done recently thinking about older women and talking about why it's important to think about things that impact them in different ways. So here we have examples of conditions that affect women uniquely, some that affect women disproportionately, and others that affect women differently than they do for men. So for example, something that affects women uniquely would be something like menopause, and we heard about that, or we heard about some of those, we heard about menstruation earlier on, so that would fit in that kind of category as well. Things that disproportionately affect women might be things that you might not realize, like migraine headaches. Women are much more likely to have migraine headaches. Another one is dementia, something that's more common in older women than it is in men. And another one that you might not think about is breast cancer, because it can occur in men, but predominantly in women. And then there's also conditions that affect women differently from men, and one of those is the heart attack example. People both get that condition, but can get it in different ways. So it's important to think about this kind of information and to start thinking about how that would help us tailor the care that we provide to older individuals. Now, when I talk about sex and gender, I always include age, and perhaps that's because I'm a geriatrician. So I think it is really important to think about those intersections. But there are many other intersections that we need to think about, and we heard about some of those earlier on today. We need to think about social determinants of health. We need to think about things like socioeconomic status relating to income and education. All of these things affect health, and we want to think about those when we're thinking about looking at diverse individuals. So it's important that we collect data and report data by sex and age and think about key identity factors so that we get a fuller look at what we're doing. Now, some basic questions about why should you consider the intersection of sex and age in your proposals and in the work that you do and the research you do. Well, I think one of the pieces is, historically, I think it's fair to say that research has addressed older adults as a single group. But in reality, I think you can see here that a 65-year-old is different than a 95-year-old, and far too often they're all grouped together as being older adults. And it's also fair to say that I think a 65-year-old female is different than a 65-year-old male, so we need to differentiate those groups. And if we don't purposely think about these differences in the work that we do, we miss them, and that leads to information that's not as useful as it should be. Now, this figure was work that was done by one of our students, and it talks about diabetes. And what you see here is you see incidence of type 2 diabetes in males and females at different ages. So males are in blue, the females here you'll see are in kind of that reddy brown color. And it goes from younger people on the x-axis over across to older people. Now, what I'd like you to see is the differences that come out between males and females with increasing age. So as you get older, the incidence increases, and there's a big difference between males and females. I also like to point out that often in data that's available publicly, there's cut points for what you consider to be older adults. And in this case, for the data, it was 75. So you're missing information about people who are 85, 95, or potentially over 100. So it kind of points out why it's potentially important to think about looking at data, thinking about sex and age, so you can see differences that might otherwise get missed. So another example of that is when you're looking at disease burden measured by DALYs. Diseases that most impact older adults in the sort of the older age groups, so those 65 to 69 are things like heart disease. But if you look at those in the older age groups, maybe those over the age of 85, it's things like dementia that becomes more common. So we need to think about this kind of information. I think when we also are thinking about age groups, and I know I'm going to talk about this a fair bit because, as I say, I think it's something really important, I think we should be looking at 5-year age groups to try to get a better sense of what's happening. Now, how can you start to put some of this information into practice? This is an algorithm that we created to help clinicians who are looking after older adults review their medications. And you can see on the left-hand side, we've got the word drugs written out. And for each of the letters, we've got some information. So D, for example, talks about that if you're a physician or somebody reviewing medications, it's important in order to optimize medications that you need to discuss goals of care and what matters most to the patient. The R is you need to review medication, the U, use tools, G is a geriatric medicine approach, and then thinking about stopping drugs. Now, what's novel about this is on the right-hand side, we started to think about what might be some of the sex and gender considerations that might impact some of the discussions you might have with your patient. So, for example, discussing goals of care, you might want to think that women are more likely to be caregivers and therefore may not have a caregiver themselves that they could bring to such an appointment to help with these sorts of discussions. When you're thinking of reviewing medications, you might remember that women use more prescribed and over-the-counter medications, so this might be something that's particularly important to them. So it's important, I think, to think about how can you use this kind of information in practice. Now, maybe a practical thing for a number of us, when we go and are thinking about submitting proposals, we're now required for many agencies to include a sex and gender-based analysis approach in the work that we're doing and to talk about sex and gender in our submissions. It's a requirement, as I say, for many proposals. And in my experience on many panels, chairing a lot of these panels, you would hear from people, especially working with administrative data, that I can look at sex and I can look at age because those variables are almost always available in most data sets and especially in the large administrative data sets that we use. But they almost always say that I can't look at gender because gender identity is not in those databases, which is true and something that needs to be corrected. But they also dismiss the fact that they could be collecting information on gender-related sociocultural variables. So these are things like socioeconomic status, that could include income or, in some cases, educational attainment or marital status could be available in different data sets. And that can actually start to give you some information about some of these gender-related sociocultural factors that are actually so important. So when we think about population-based data, which is a very powerful tool to identify health inequities and reduce disparities, I think it's really important to think about incorporating sex and age disaggregated data and thinking about their intersection in all the work that we do. And to think creatively, because sometimes it's not obvious, so think creatively about how gender-related sociocultural factors can be leveraged to help us better understand whatever we're looking at and to improve health outcomes for older adults, women and men. And I'll end with information about a module that we've got that helps people who are looking to think about sex, age, gender, and the work that they're doing. It talks a lot about sex and age disaggregated data, why it's important, and how you can use it more effectively. It's an interactive module designed by Robin Mason, who's one of our scientists who's done a lot of work in this area, as well as Joyce Lee, who's our senior research lead, and one that I think you'd find really helpful. And I'll end by saying, incorporating sex, gender, and age, which is my add-on, into health research is so important. And I think it's something that we really want to encourage and support researchers everywhere to do across the province, across the country, and internationally. And in so doing, hopefully we'll improve the research that we do to benefit all. Thank you.
It's an honor now to present our third speaker, Dr. Andrea Lum, who hails from Western University, where she's the Vice Dean of Faculty Affairs, and this is at the Schulich School of Medicine and Dentistry. She's been very engaged in many leadership roles across the country and intense work at London Health Sciences, Centre St. Joseph's Healthcare since she went to London in the year 2000. She was awarded the Canadian Association of Radiologists Gold Medal in 2021 for outstanding contributions to the association and to the profession of radiology as the fourth woman recipient. She's program director for the Diagnostic Radiology program, and in that time has been working very heavily with postgrad ed and the director of abdominal imaging for the radiology resident training from 2005 to the present. She has got extensive experience background working with medical and radiology associations, and through her leadership has influenced physicians, professional staff, and trainees throughout her own institution and beyond, especially in the 2018 Accreditation Canada survey, which was awarded as an exemplary initiative. And she leads clinical operations at the Ivy Business School as well, focused on mentorship for women and physicians. So welcome, Dr. Lum. Thank you so much for being with us today.
Thank you very much for inviting me today. And as part of my disclosure, I'm here because I know Dr. Robin Walker, and Robin and I have worked together for many, many years. I am not an expert on EDI, DI, DEA, or whatever the acronym is. But what we've heard this morning is that you have now been given very tantalizing information on AI, as well as on sex and gender. You know the why, you know the what, but how are you going to do any of this? And without an implementation process, it just sits. As I know, and Robin knows, many times we develop these policies, procedures, and they're big tomes in the days where we printed everything out, and they sit on a shelf. I am employed by Western. That is our dog, and I do committee work on the Medical Women Foundation Committee. So that's what I'm going to do today to help you and the PSI Foundation take it to the next level. So the first thing I did when Robin asked me to do something today was to actually say, what is your current mission and vision? And of course, we heard this morning from Robin as well that you're undergoing the next 5-year plan. So this is the right time to think about exactly how you're going to make all the interesting points that were presented this morning come to life. I've been giving quite a few talks these days. I guess it's my pre-retirement stuff that people are asking me to do. And I started reflecting about career culture. This is my full-time job. I'm the Vice Dean of Clinical Faculty Affairs. I am a radiologist, but I do very little radiology practice. During COVID, and it's really a little bit hard for us now to remember, except that the new vaccines are coming out soon. But back in March 2020, I will say that there was almost a panic within physicians, within healthcare, as to what to do for COVID. We don't really remember all those details, but it was really a very traumatic situation. We were no different at Western. Physicians and our healthcare partners, we really didn't know what to do. And in particular for physicians, we had no support. We talked about it, just like you hear, we had our vision, we've done surveys, but we actually didn't have any tangible support. So I am going to talk about peer support and well-being as one of the examples in how to innovate change. But as I was reflecting upon this, I also reflected on our mentorship program, and I will reveal the truth to you. In 2011, Schulich at Western developed a mentorship program. 2011. It has not been implemented until 2023. Recall what I said? You do a document, everybody's great, it's a policy, we brought it through all the councils, and it sits on the shelf. I'm seeing a lot of nodding heads. This is our experience. We hear a lot now about coaching skills. Many of you probably do this intuitively, and I'm going to embarrass Robin on this. See, Robin, you invited me, so here it goes. Robin and I, when Robin retired from his integrated vice president role, I was really hoping to retain his expertise. And I said to Rob, Robin, I'm thinking about developing a coaching plan. Robin, you recall this. This was one evening where we were meeting with a colleague, and Robin says to me, but Andrea, I'm not a real coach. And I looked at Robin, I said, Robin, you are a real coach. You've just not been branded that. And today, truly, you can't be a real coach unless you've been certified. So don't get me going on that. The other part of this circle is sponsorship, okay? And I'm sure every single one of you have experienced sponsorship in some form or other. Maybe you don't realize that. If you walk through a door, that's sponsorship. Somebody held the door open for you. Somebody tapped you on the shoulder and said, hey, this PSI Foundation, blah, blah, blah. Maybe you might attend because maybe this is going to help you in your career. So that's another important aspect. I am not going to talk about all of these aspects, and it will become clear later on. But just to give you that visual, I'm a radiologist. So I don't know how many of you have heard about Mary Lippitt. Probably none of you. It was a chance social media thing. I'm on LinkedIn, somebody posted this, and I looked at it and I read it. And I can do this now without thinking, and I will reveal to you at the end how this came to fruition and how Kelly McShane came to present as a substitute, because if I could not have done this within half an hour whilst co-chairing new faculty orientation, you would have not had a third speaker today. When we want to do something, the most important aspect of implementing anything are your people. And I'm a radiologist, so I like the technology and the AI, and I wish a lot of the things have been implemented yesterday. But without people, nothing is going to happen. And do you know people are the hardest to change? Okay? I'm a grandmother, got a 2-year-old, and my 2-year-old granddaughter is now discovering the word no. No, Mom. Would you like apple? Nope. Would you like orange? Nope. And it's just a fascinating thing to discover that. She's not much different than the 2,500 faculty I have to deal with. 1,000 full-time in London and 1,500 in our community network. And so whatever you end up doing, we are people. We're not robots, we're not chatbots, we're not whatever bots there are. The other thing is, if you don't have a process or procedure, you're going to be having these issues. So if you look on the top line, this is a bit awkward, but I'm going to try to speak this way. If you happen to have vision, and I add mission to this, so this is Lum's modification, skills, incentives, resources, and an action plan, voila, you have change. It is brilliant and it works, and I will show you some examples. If you don't have a vision or mission, and many of you will reflect on this, you will have confusion. So nobody knows what they're supposed to be doing, where are we going, what is this all about? If you do not have skills, you have no skills. See, I was fascinated at some of the technology our computer expert was, and I'm thinking, oh, I don't have those skills. If I were going to do that, I would have a lot of anxiety. I don't know what I'm doing. Incentive is the key for people. Incentive is the secret sauce. If my 2-year-old has no incentive, will not do that. Actually, she's very good with grandma when we go on walks. If her mother takes her out for a walk, she doesn't want to hold hands, she runs around, and she has no incentive. But grandma has found her incentive. And grandma's incentive is very simple. We're going to find colors. She happens to like purple. Purple is grandma's favorite color because I work at Shoal Lake and Western. And we go around trying to find the purple flowers. This is a true story. 2 days ago, grandma took her out for a walk, holds my hand the whole time, does not let go. And then when we go together with her parents, she lets go, she runs around. Grandma's going, oh my God, you're going to run out into the street. If you do not have resources, and that's the R word, that's the B word in my life now, called budget. Okay, I hope there are no financial people here. If you have no budget, you can't fix the hole in the ceiling, in the OR, so that when the accreditors come, they say, oh, there's a nice tube here. Why didn't you get that fixed? You knew you were coming. Robin knows this story because he worked with me on that. And if you have no plan to follow, it becomes very frustrating, and you're not communicating out. I'm co-chairing a selection committee, and I'm trying to get some procedure and plans. And people have so many questions because they're unsure as to what is happening next. Last night, I got an email, blah, 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 blah. So sometimes it's so important to do this. I'm trying to work through my dean to get him into this. But so the way I explain this is, we all go on vacation, don't we? So some of you might like to go on vacation, and if you haven't done this, you will then come and say, oh, it was a staycation, it was a lovely time, I liked it. That's because you didn't know where you wanted to go, you didn't know what you wanted to see, you may not have the skills to book the vacation. That would be my husband. He does not know how to book online, but he likes to pretend because he says he goes on vacation all the time because his wife books it. You know, and if we've grown up adult children, they like to choose the accommodation. Mom likes to let them think they're in control, and they pick the resort. I'm all good with that. What do they want to do? Is it an adventure thing? Is it rest and relaxation? And most of all, do you have resources? That's when, you know, I said to a colleague the other day, very happy that they're empty nesters and they think that their grown-up children won't rely on them. And I started laughing. I said, yeah, wait till you go on vacation and you have to foot the bill. And then your whole action plan. And you know, your children will ask you, where are we going? Have we gone there yet? What are we going to do? So it's not hard. We do it all the day. Take that and translate into your biggest project. Okay? And you will see what happens. So my first challenge, and it was alluded to, I was the new medical advisory chair back in 2016, something like that. And you know, welcome Dr. Lum. we're undergoing hospital accreditation. And for those of you who don't know about hospital accreditation, it's a big deal. But typically, physicians are not so involved. But Accreditation Canada wants physician engagement. And how to get physicians, and particularly the leaders, your heads of department, engaged in helping with this activity. So I did. I found the secret sauce. And the secret sauce is under incentive. In an academic health science center, and Teresa, are you taking notes? If your physicians lose all their learners, aka residents, that's not a good thing. It's not a good thing, right? If we don't pass accreditation, the learners go elsewhere. Now you can say London Health Sciences is a large academic center, and I'm not going to disclose anything. You just need to Google London Health Science Center, and you will find all the lovely things that are happening in our city. We're under supervisor right now. If we do lose accreditation, every single department is going to be impacted, right? So this is not an Andrea Lum activity. I cannot do this myself. I cannot be everywhere, although I can walk in my high heels. I love the shoe image there. And I have visited every single department, every site. So we engaged our heads to do this. And the story goes, I went on vacation, came back, and the administration said, we've got blah, 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 28 required organizational practices, and we want physician leaders to be there. And I said, that's great. They handed me a form, and I looked at it, and I said, how come there are all these blanks? Well, we put the ones that we thought would be engaged. And I said, no. This is equity. Every single head of the department is going to be added. And sometimes we needed to put 2 people, and we went down the division level. And we're just going to distribute out. And they looked at me as if I was a little bit, this is a radiologist. She's not thinking straight. Maybe she needs an MRI of her brain. Well, it happened to be the December meeting, and I just started my role in October. I went and spent some money. I bought chocolate bars. I assigned it all to everybody, put it in a nice greeting, and I came from Ottawa, so I did the civil service sandwich. In case people don't know what that means, you say the congratulations, great, it's festive celebration, and then you end with here's a chocolate bar for you, and in the middle you put the meat. You have been assigned to this ROP, and we did that. Everybody thought they were getting a festive gift, but in fact, they were being assigned. And it did work. To reveal some psychologically safe information, the hospital had been put on attention, you call it attention, for the 3 cycles previously. Had we not achieved success, they were seriously considering non-accrediting the organization. But not only did we achieve success, we got exemplary. Okay? As a result, that's always a good and a bad. They contacted me, and can I help develop their new accreditation standards? It's a whole new module, so for any of you who are hospital administrators, please don't blame me. And we shifted the culture. That was my first taste. That's when I learned about this model. Okay? I didn't know anything about that. But since then, I've been quite an expert on that. So it does take a lot of hard work. This is not easy. I make it sound quite easy. Robin knows it was not easy, but we can do it, and we can do it together. And it's the iceberg analogy. As I say, I'm a radiologist. The second challenge is what I alluded to, and that has to do with the COVID pandemic. So in March 2020, I was vacationing in Aruba when I started hearing that airports were going to close and maybe I might not get back. That's not a disaster for me because I was actually staying at my aunt's place and we were having a great family time. So, I could have worked remotely. But anyways, I got back to Canada only to find that I was denied my first 90 days as being a vice dean to figure out stuff because now we had COVID. We were meeting daily on what to do. And I recall very clearly that we had an interim dean at the time, Dr. Davy Chang, and I said, Davy, we have nothing to help our physicians. And he said these words to me, okay, Andrea, just do what you can. That's all I needed, do what I can. So we did not have 13 committee meetings to come up with a vision and mission. You guys all know about that, right? You have to all discuss, and it goes around and around and around. It was actually quite simple. We just simply needed to help our physicians. And nobody was going to do it for us because all the big names could not come into Canada. We barely knew how to use Zoom or Teams. You can tell I'm not so fond of one of them. And we had to use our resources. But, well, you think about it. You are a university. You have 1,000 full-time faculty. Surely we could find some experts. By the way, I knew nothing about peer support. Some of the things that I learned with everybody else. What I did know, though, was I was a chair previously, and I chaired the MAC. So I had this amazing network, okay, of leaders whom I can lean upon. And that's what we did. The incentive is that if we do nothing, we're even going to have higher rates of burnout, etc. And so you can see we came up with an action plan. How fast was this done? This was done within, I'm just going to move forward, within a short period of time. But you can see I translated what is on the left side, the Mary Lippett model, into vision, incentive, skills, resources, and action plan. And at Schulich, the clinical faculty affairs, we're just here to guide our physicians. So this is how fast it came through, from March 23rd to implementation and skills training, April 22nd. And we were training ourselves while doing this. We had to. There was no choice. We were training me, the leader, too. And I would sit there and go, oh, so this is what all this is about. But we were very fortunate. We did have very clear needs assessment. Okay? We are in the academic milieu, and we always need to have that. So what we fortuitously had was we already had done a survey back in January of our medical staff, our professional staff, and we knew that there was already this underlying level of burnout and anxiety. And we also knew that when people responded, that speaking with a colleague was helpful for them. So that's all we needed. I didn't have any other clear evidence but the survey spoke volumes. Sometimes when you talk about sponsorship, and this is how we landed with the Airline Pilot Assistance Program, I had, as a happenstance, been sponsored or introduced to the Air Canada facilitator for the peer support program of airline assistance. And if you think about it, pilots are not so different than physicians. Most of us work in multiple different sites, diverse environments. Even if we're in the same department, we might not see each other except at a departmental meeting. And we're very distributed, whether we're in a designated academic healthcare facility or in clinics or in our own office practices. And you need something that's everywhere because the individual that's leading this cannot be everywhere, okay? And so I was about to actually take this airline assistance program because the facilitator was very kind and said, we hold boot camps. We hold one in Western Canada, one in Eastern Canada. You know, the next one is in Calgary, and I was almost all set to do this, and then COVID came upon us. So I did not receive the training. The key difference between the pilots program and a physician peer support program is that we are doctors. We have had our medical training. So the pilots program did focus a lot on content, but at least I'm a radiologist. I do remember some medical stuff, and all of us together, we didn't have to go right down to basics. So we can do an expedited program. What we also did was we brought together the concept that if we had a well-being lead in every single department, then they would be the nidus that would help each and every one of their faculty. And your immediate thinking will go to, wow, some departments are really big. Well, we did end up within larger departments, like our Department of Medicine, it has 300 faculty. We did divide them up into divisions. But I didn't tell them what to do, because their leaders know what to do, and one size never fits all. So the Department of Surgery had divisional leads. The Department of Medical Imaging had site leads. It's whatever fits for their department. So what exactly was our peer support program? It was basically based on empathetic listening, providing peer support, all these things but we did realize we needed training, and I'll get to that in a second. But we also needed to educate our leaders, because not all leaders understood peer support. And part of the implementation was presenting at forums like at the Medical Advisory Committee and to our clinical chairs. Okay? Resources were really important, and we are resource in terms of human resources, because at Schulich, I have a role, and we already had an assistant dean of faculty well-being, which was in the process of being recruited. At the time, when COVID hit, we were undergoing transition. One person was finishing their term, and one person coming on. We needed to develop a curriculum, and there's so many great resources within many of our faculties. And ultimately, for the sustainability of a program, we needed to have team support. So this is a snapshot of our program, which we had developed during COVID, and training modules. And we didn't even have the online tools to really develop this at the beginning, so we did it very easily. We recorded the Zoom presentations, and it was raw. Now we do have a more polished modules that we have. So as you can see, if you go through a very systematic process of how to do that, you can achieve what you want to do. And that segues into the future of, this is just the action plan for PSI Foundation, right? Whatever you choose, and Rob and I talked a little bit about this. So if you want to incorporate sex and gender into your grant process, how are you going to help those individuals do that? Are you simply going to post it on LinkedIn or on Twitter and say, this is, add this to your proposals? Are you going to help people? The single most problematic resource lack that we have at our universities is we don't have those research assistants, we don't have those mentors that can actually walk you through your specific process. So at Schulich, we do have that, but they're only for the top level granting agencies. The Tri-Council, the CIHR, we have that. But if you want people to start doing research, they might have a wonderful idea, but they might not know how to do it. So at Schulich, we have a robust mentorship process where we train both the mentees and the mentors as an online module. We have a matching tool. It's not perfect. We would like to buy an expensive tool, but we've got a homemade tool where mentors can put themselves on the website. And that flows into career development planning. So you're mentored through your process. Grandma holds the 2-year-old hand. She will eventually know how to walk down safely the pathway and not cross the road and kill herself. So you do that for a period of time. The career is continually developed annually, particularly for our assistant professors, so that ultimately Schulich Weston has mandatory promotion to associate professor, which is why I am funded. They achieve promotion. Okay? So if you think about PSI, what do you need? If you're thinking, is mentorship important? Why is it important for your organization? What is the goal? If your goal is to set some targets on increasing sex and gender participation into your grant funding, then you're going to have to think about what you need. Who's going to lead this? Who's an experienced leader in mentorship? Because you're going to need someone to lead it, as well as actually having the mentors. And I already heard a little bit that Robin mentioned at the beginning, that you're already gathering some of your data. What's your database? What is your now to know what you want to go to? But you will need some resources. This cannot be done on a shoestring, right? You will need some research assistance. You will need infrastructure in order to achieve that. And then once you have all that, and an action plan and a timeline, and if you have all of those, then you will actually achieve change. And with that, I'm going to close, and thank you so much for inviting me. This is Jasper, and he's our Maltese. Thank you very much.